Hi everyone, today we are going to analyze the case of the right breast cancer. We are group 6, I am Kwan Pui and my groupmate are Lui Kam Yuen. Here's our content page. To begin with, we will talk about the patient demographics. In our case, the patient is a 40-year-old female. She does not have any smoking experience and have 2 daughters. Her mother died of breast cancer at 42 years old and her younger sister, who currently age 38, is having a benign tumor at 32 years old. She does a surgery after diagnosis and now already fully recovered. Our patient performed self-breast check monthly and found that there's a lump in September 2016. For breast cancer, the following are the signs and symptoms: painless lump in breast, no cold tenderness, lump in armpit, changes in breast shape or size, skin changes, dimple or pungus, orange pale skin, itchiness or soreness of dimple or breast discharge, etc. But in this case, our patient only has a painless lump in the breast as a symptom. There are many types of investigations done by the patient: past clinical history, physical examination, which may be a breast palpation, a bilateral mammography, and core needle biopsy. There are 2 reports from the mammography and the core needle biopsy: the pathology report and mammogram report. From the report findings of the bilateral mammography, we know that there are bilateral heterogeneously dense breasts, which is a term used in mammography to describe breasts with a higher percentage of glandular and supportive tissue than fat. Dense breast tissue makes breast cancer screening more difficult, and this increases the risk of breast cancer because breast cancers and the glandular tissue appears of the same color, white, making it more difficult to detect cancer, running the risk of having their breast cancer missed during the early stages of development. So to determine whether a patient has dense breast tissue or breast cancer, they usually determine the ratio of non-dense tissue to dense tissue and assess a level of breast density. Levels of density are described using a result reporting system called Breast Imaging Reporting and Data System, BIRADS, and for our patient, she has a BIRADS category 4, which means it is suspicious abnormality and is having a low to moderate probability of cancer, so biopsy will be considered. Also, a benign macrocalcification is seen at the inferior aspect of the right breast, plus 2 scattered benign microcalcification are located under the right nipple and at the superolateral aspect of the right breast. There are 2 types of breast calcification: macrocalcification and microcalcification. Macrocalcification look like large white dots on a mammogram and are often dispersed randomly within the breast, usually non-cancerous, and microcalcification are small calcium deposits that look like white specks on a mammogram. Microcalcification are usually not a result of cancer, but if they appear inside of precancerous cell or early breast cancer, the microcalcification will be determined to be either benign, probably benign, or suspicious. In this case, it is a benign microcalcification. For benign calcification are considered harmless. No further evaluation or treatment is needed. The small cluster of microcalcification at the superolateral aspect of the right breast shows pleomorphism. They usually need to be investigated further to rule out malignancy of breast cancer. They do not always turn into cancer. The other findings are normal, like no abnormal focal density, malformation, or architectural distortion in present, no nipple retraction is seen, no focal skin thickening is evident, and no axillary lymphadenopathy is observed. From the report findings of the pathology report, the core needle biopsy gets the specimen from the right breast lump in the direction of 10 o'clock, 5 core, 10 soft tissue, which measure from 1.2 cm to 1.5 cm in length. 0.1 cm diameter is the entire centimeter in A1. According to the breast pathology crossing guidelines, A1 stands for shape of base of nipple in a superb cassette. The cores of breast tissue are extensively infiltrated by invasive ductal carcinoma in a desmoplastic tumor. The tumor is composed of irregular cores, tubules, and trabeculæ of tumor cells with 10% to 75% tubule formation. The neoplastic cells show marked nuclear pleomorphism with coarse nuclear chromatin and occasional prominent nucleoli. Mitosis is not obvious, consistent with SCORE1 according to the scoring system. SCORE1 stands for the acinar is not more than 75%, which means the cancer cells do not grow aggressively, but may be an underestimation as assessment is limited by sampling effect. Intermediate grade ductal carcinoma in situ component with solid growth pattern and comedule necrosis is seen in the specimen. Comedule necrosis describes a situation where the entire breast duct is punctured and there are dead cancer cells scattered among the live ones. It is categorized as high-grade DCIS with a high risk of escalation. There is no definite lymphovascular invasion noted, which means no lymphatic spread and blood spread of the cancer cells. It is confirmed that the patient is suffered range from ductal cell carcinoma grade 2 with staging 2A. After the patient undergoes lumpectomy, from the pathology report, the patient HER2 and ER is positive, which is a hormonal therapy and target therapy. The treatment modalities in this case is surgery, chemotherapy, radiotherapy, target therapy, and hormonal therapy. To start with, we will talk about surgery, which is the first-line treatment. The patient undergoes a lumpectomy with breast reconstruction, a 4 cm diameter tumor by removing the tumor. This makes the cancer cell become minimally invasive. Also, she has a breast reconstruction with silicone gel. Both provide good cosmetic results. The chemotherapy that the patient possesses is a treatment with 6 cycles. Combination of drugs is implemented because it is more effective and it aims to reduce the chance of breast cancer recurrence and improve both disease-free and overall survival so that the patient can have a better cure rate. And for the radiotherapy, the patient is treated by 2 fields, which is tangential opposing technique using field-in-field technique and half-beam block technique, and electron boost to tumor bed for the first field. The setup is using 6 MV photon to give 2 gray per fraction and 100% isodose level daily to 50 gray and refill, no bonus. And for the electron boost to tumor bed field, its setup is using 12 MeV electron beam to give 2 gray per fraction and 95% isodose level daily to give 10 gray and stop, with 1 cm bolus. Field size 6x5 mark on skin, shoot on the skin appearance with a supine position of the patient or number 1 breast block and arm rest. Now I will pass my time to Lui Kam Yuen.
I'm Lui Kam Yuen and I will continue with radiotherapy. A patient with high risk for local chest wall, regional lymph node failure, or perform lumpectomy instead of mastectomy need to receive radiotherapy. Radiotherapy aims at minimizing the rate of local regional tumor recurrence, killing any small areas of cancer that will not seem but may remain, and improving the survival of the patient. In this case, there are 3 techniques being used in order to optimize the treatment plan. First, using half-beam block technique will block the lower half of the field and there will be no beam divergency. It helps reducing radiation to normal lung tissue. Second, the field-in-field technique can avoid overdosage and improve the homogeneity of the dose distribution. The field weight and the monitor unit change interfactionally, and it can improve the homogeneity of the dose distribution too. However, there are some concerns about the treatment plan. Central lung distance is one of the issues that needs to pay attention to. The volume of lung being irradiated should be as little as possible. Radiation pneumonitis risk will be lower than 2% with central lung distance less than 3 cm, but it will risk up to 10% with central lung distance around 4 to 4.5 cm. The impact of breathing motion need to be considered too, as it will disturb the delivery of radiation to the target volume, and the nearby organ at risk will get irradiated, but it is more significant when treating left breast cases. It can be solved by using active breathing control device. Also, many patients will live for decades after treatment, so it is important to minimize the technical factor associated with long-term complications, especially for the lung. And now, talk about the side effects of radiotherapy. Side effects are different from person to person, and here are some commonly seen side effects experienced by breast cancer patients, such as skin reaction like dryness, itching, and swelling of breast, pain in breast or chest area, hair loss in the armpit, fatigue, lymphedema, change of breast shape, size, and color, tenderness over the ribs. After radiotherapy, patients receive target therapy, chemotherapy for 1 year, and hormonal therapy for 5 years. Target therapy, which also called anti-HER2 therapy, is prescribed to the patient as she is HER2 positive. Herceptin, which is a monoclonal antibody, can suppress the overexpression of the HER2 gene and stop the HER2 receptors from signaling tumor cells to grow. And with the use of Xeloda, which is a chemo drug, can interfere with the growth of the cancer cells and slow their spread in the body. Because patient is ER positive, hormonal therapy is prescribed to her. Tamoxifen, which is a drug used, can effectively block the action of estrogen on the tumor and improve the disease-free and overall survival of the patient. Although it has a very low rate of significant side effect, patients may experience hot flushes, vaginal bleeding, and vaginal discharge occasionally. Furthermore, taking tamoxifen slightly increases the risk of cervix cancer. Here shows the treatment timeline of this patient. It follows the common breast cancer management for premenopausal patients. First, patient underwent lumpectomy and breast reconstruction. Next, chemotherapy was prescribed, followed by radiotherapy, and finally, target therapy, chemotherapy, and hormonal therapy were prescribed. After the treatment, patient must keep on monitoring her body, performing self-breast check for both breasts. If she found any abnormality, she should seek consultation from doctor. Taking regular mammogram and blood tests can help detect any microscopic change at early stage. Also, she may have an annual pap smear as the risk of her having a cervix cancer is increased. Bringing it back to radiotherapy, in this case, tangential field was used, and it offers several advantages. First, satisfactory dosimetric result can be obtained. Then, because it is a simple setup, it is reproducible between treatment. Also, its treatment time is relatively short. Cooperating with half-beam technique, radiation to normal lung can be reduced, but part of the lung is still irradiated, and it may induce radiation pneumonitis. Therefore, we think there are two treatment options that can overcome the weakness of using tangential field. The first one is proton therapy, as the beam falls off rapidly and the exit dose will be very low. It can significantly reduce the radiation to the organ at risk, such as lung, ribs, and heart. But this technique has not developed in Hong Kong yet. The first proton therapy system may be launched in Hong Kong by 2020. By that time, the patients can benefit from it as it can provide a better dose distribution. The other treatment option is prone breast. It can minimize the radiation to organ at risk and thus lower the risk of complication. It can also deliver a homogeneous dose at the target volume. However, it is not suitable for most Hong Kong patients as it requires a large breast. So, tangential field may be the best treatment option now for a breast cancer patient. This is the end of our presentation. Thank you. And here is our reference.